during the call. Thank you so much for being here. I'm Caleb Lavelle. I'm the Strategic Director at the National Partnerships at the American Cancer Society. And I'll be joined by Sarah Schaefer as we kind of orient the group to the conversation that we're going to have. So to kick things off, just making sure everybody is at the webinar that they think they're going to be at today. So just really quickly, kind of a welcome and purpose what we're doing. Today, during this conversation, we're going to be hearing from some renowned experts from the American Cancer Society, the American Cancer Society Cancer Action Network, the Commission on Cancer, the CDC, and from the President's Cancer Panel, to really explore the key areas that we have around alignment and the implementation of evidence-based and emerging cancer control activities. We are also going to be looking at, there's been a lot of challenges that have arisen in the wake of the pandemic, and there are many solutions that we already know can kind of improve access to quality cancer screening and care. So objectives as we're going through the day, looking at identifying critical barriers, preventing the nation from reaching these improved outcomes, accelerating the adoption of proven interventions and other drivers to influence change nationwide, and to explore where the pandemic has necessitated innovation and expanded our capacity in cancer screening and activity. Today's agenda, right now we're just going through introductions, some technical orientation, general housekeeping. We'll do about a 15-minute presentation and then straight into discussion and some polling and some different interactions with the audience members. Virtual housekeeping. The event is being recorded. The replay and the slides will be made available within a few days, and you'll be notified via email. All the participants are going to be muted. We're really just going to be listening to our expert panel that we have here. We are offering some participation in polling opportunities and general discussion using Slido. So we'll be talking about how you get into Slido in just a second. For Zoom, you can ask questions through the Q&A box for technical questions only. We have a couple of really great discussion leads that'll be helping us guide the conversation today, and then the panelists themselves will also be guiding kind of where the conversation is going. We will have an evaluation for further input and feedback, so we do ask that you complete that at the end. And as another follow-up for this particular session, in a couple of weeks or so, we will have an issue hub brief, a summary that will be shared with all the attendees that are here today. So we are looking for instant reactions today, and we're doing that over at slido.com. So please do use Slido to answer polls, share instant reactions, and just general comments, having your kind of own discussion as panelists as we're listening together to the panel we have here, or your own discussion as attendees as we're listening to the panel that we have here. You can open up Slido and enter meeting code JuneHub, or use the link in the Zoom chat that we're sending out. And you can use a computer or mobile device. If you have two screens, it's great. Or if you just have your cell phone, you can pull it up on your cell phone, and it makes it nice and easy for you. If you go to the website and you go to slido.com, you'll see at the top there's a joining as participant right there. That's where you'll enter in June Hub, and that'll get you into the event, and you'll start seeing a live poll that should be up right now. So you do have a practice poll up. If you go into the event, you'll see on the bottom there, we have the screen that you'll be seeing once you get into the Slido, and you can go to the polls tab and start responding to that poll. So we'll just pull up that poll really quick and make sure that folks are making things happen. Okay, so it seems like we have some votes coming in. Uh-oh. Computer's freezing just a bit. There we go. And apologies as I'm pulling this back up for us. Well, we can see the results here. I won't go to the live screen, but we can see the results going in right here. So we're asking today, which of the following describes your music listening tastes? And a lot of people are saying playing my favorite band on repeat. Please keep going in there. Try to interact with the polling. We'll be doing this throughout. We'll get the technical glitches resolved and make sure that you all can interact with us throughout the session today. The other place that you'll be interacting at the top of the tab is an ideas tab. We have a couple of different places that you'll be being able to comment. As you're commenting, you'll see that there's a place to kind of type in what your particular topic that you want to, whatever we're discussing, you'll be able to kind of type your responses. You'll be able to sort by popular or recent posts. You'll be able to upvote any comments that any of your colleagues are making in the session. You'll be able to upvote those to see which ones that you like the best. And you'll also be able to reply to some of these topics. We'll be recording all of these responses and being able to use these as we're kind of putting together our assessment of what you're all telling us today and how we really want to kind of get to some driving recommendations that come out of this particular issue hub. So with that, I'm going to pass over to Sarah Schaefer and let her walk us through, make sure we get some contextual information about what we're talking about today.
Great. Thank you, Caleb, and welcome everybody. Really pleased that you're joining us today for our National Consortium Issue Hub. And I'd like to begin by celebrating our progress. So collectively, we've made great progress toward reducing the national cancer burden. This year, we celebrated a new record for the largest one-year drop in the cancer death rate. The overall cancer death rate fell 2.4% from 2017 to 2018. This is largely due to advances in cancer screening and treatment technologies, research, public education, resulting in improved uptake in screening services. We're going to go forward to the next slide. And we're going to take a look at a trends graph that shows cancer death rates by both genders between 1975 and 2018. In here from 1991 to 2018, we saw a combined death rate drop of 31%. And then our next slide shows the total number of cancer deaths averted from 1991 to 2018. As a result of the continuous decline in the death rate since 1991, we've seen an estimated 3.2 million fewer cancer deaths through 2018. So much to celebrate there. Recognizing inadequacies is important, however. Far too many individuals for whom screening is recommended remain unscreened, and many others lack access to care. We must consider specific efforts to reach vulnerable and underrepresented population groups. So confronting the alarming consequences of the COVID-19 pandemic is essential. The pandemic caused disruptions in healthcare access and cancer screening. As a result, there will be a short-term drop in cancer diagnoses and increases in late-stage diagnoses, resulting in increased cancer mortality. The pandemic has exacerbated social and economic obstacles in disproportionately affected, disadvantaged, and underrepresented population groups, leading to increased disparities. These outcomes will be devastating and plague our work for years to come unless we respond relentlessly, emphatically, and collaboratively. So what we know, we saw early in the pandemic significant disruptions in the healthcare system, which had a huge impact on cancer screening. In spring 2020, breast cancer screening dropped 87%, lung cancer dropped 39%, and colorectal cancer screening dropped 90%, as reported by the Equivia Institute in April of 2020. By the end of summer 2020, there were several reports published that showed a rebound in cancer screening. Here on the screen, we have a sampling of those reports that are referenced here with hyperlinks. So once you receive the deck, you can take a look at a sampling of the reports on the rebounding. We do need to look at more data to better understand the full consequences of the pandemic. With the subsequent COVID waves, where there are additional dips in screening, is recovery seen evenly across all population groups, across socioeconomic demographics? Is recovery comparable across geographic areas? How have health systems handled the backlog of missed screening missed screenings. These are a few of the questions that the National Consortium will strive to answer through future webcasts and issue hubs. So we hope that you'll join us for those future discussions. The American Cancer Society is coordinating a multifaceted initiative engaging public health, health systems, screening, and patient advocacy organizations, federal agencies, and industry partners to promote cancer screening appropriately, safely, and equitably. This multifaceted initiative is organized around 6 building blocks. The National Consortium, one of those building blocks, is convening national leaders in cancer screening and care to help identify strategies to best minimize the effects of the pandemic. The American Cancer Society has recently launched a public awareness campaign called Get Screened. Our research department is continuing to study the impact of the COVID pandemic on cancer screening and outcomes. We are also engaging state and coalition leaders in developing effective public messaging, working on policy initiatives and other opportunities to reach our goals. And we have a pretty robust health system screening interventions work that is engaging over 50 health systems, including federally qualified health centers, integrated delivery systems, and hospitals to work on evidence-based interventions to increase screening rates. And our policy work led by ACS CAN, our Cancer Action Network, is pursuing public policy solutions to help ensure individuals have access to timely and appropriate cancer screening and follow-up care. So I do want to acknowledge our funders. We could not do this initiative without the generous support of Genentech, Pfizer, Merck, the National Football League. And I also want to give a huge shout out to our National Consortium members. We can take a look at the next slide for the diverse list of members who have joined us at the National Consortium, many who are on the telephone or on the Zoom call today. The National Consortium is united in recovery and improvement. We are issue focused, we are time bound, we are a partnership working to accelerate a national response to the COVID pandemic. We are organized around 3 main goals. Accelerate. We want to accelerate our responses to longstanding and emerging barriers to cancer screening and care. We want to strengthen our preparedness, infrastructure, and partnerships to minimize disruptions and address inequities. And we are mobilizing around sustained, coordinated commitments to promote cancer screening and care as a public health priority. Today's issue hub is focused on accelerate. We will have 2 other issue hubs throughout by the end of the year that will focus on strengthen and mobilize. I'm going to turn it over now to Caleb, who's going to tell you a little bit more about how today's issue hub is structured.
Yeah, thanks so much, Sarah. And again, so the issue hub that you all have kind of logged in today, we're really trying to utilize this platform, these issue hubs, to join together to tackle the most pressing issues in the recovery and improvement of cancer screening and care, to not only hear the voices around the National Consortium table, but also hear the voices of folks that can join this call, that can weigh in, that can give us ideas of how we need to press on as a nation and improve our screening and care quality. So the issue hubs, as Sarah was discussing, the ACS will host a few of these in 2021, primarily aimed at informing future conversations and decision-making of the National Consortium. These are going to be conducted, you'll see today, as facilitated panel discussions with renowned subject matter experts tackling the most pressing issues in recovery, improvement, cancer screening, and care nationwide. We really hope that these discussions can serve as kind of deep dive discussions and uncover both the strengths and opportunities that we have in cancer screening care, as well as what our current barriers are, a really honest and transparent reflection on the limitations we have in our national and local efforts. As we host these issue hubs, we will definitely look to include more stakeholders, rotating panelists, and so that we can hear from a variety of public health leaders, researchers, clinicians, and other appropriate thought leaders. And then, we are trying to keep these as open as possible and really do want to engage a large audience. And we'll find different opportunities to weigh in as as the National Consortium is delivering on recommendations or other actions that we can take as a nation, or we can take as, committing as individual organizations or as public health individuals and leaders ourselves, that we can do to play our part in reaching our goals. So just here, these more issue hubs are being planned kind of tentatively. We're thinking of, Accelerate happening in June today, Strengthen sometime in August, and Mobilizing, the talk coming in November. Just to kind of re-highlight the focus of today, we went over the objectives. We're trying to identify and prioritize those proven interventions that increase cancer screening rates, accelerate the adoption of these interventions nationwide, explore where the pandemic has necessitated innovation and expanded our capacity in cancer screening activities. And really the true purpose is to bring together ACS, ACS CAN, CDC, the Commission on Cancer, the President's Cancer Panel, and to have a candid discussion about longstanding barriers in cancer screening and care, and ideate on bold solutions that will accelerate national interest towards improving cancer outcomes. It's impossible to have a discussion that won't have some reflection on the disruption that the COVID-19 pandemic has caused, but a lot of the barriers and a lot of the solutions that I think we have will definitely come up and have been known and have been in discussion for a long time. So it's reprioritizing, it's thinking about how we can mobilize around this and really get the kind of the re-energization we need coming out of the COVID-19 pandemic. I'm really honored to be able to announce kind of the panel that we have for this discussion today, who will be interacting. Keisha Brooks-Coley as the Vice President of Federal Advocacy and Strategic Alliances at the American Cancer Society Cancer Action Network. Dr. Timothy Mollett is the Chair of the Commission on Cancer of the American College of Surgeons. We have Dr. Lisa Richardson, Director of CDC's Division of Cancer Prevention and Control. We have Dr. Bob Smith, Senior Vice President, Cancer Screening at the American Cancer Society, and Dr. John Williams, who's the current chair of the President's Cancer Panel. Today, our discussion lead, I believe, will be Dr. Richard Winder. He's the chair of Family Medicine and Community Health, University of Pennsylvania. He's also the chair of the National Colorectal Cancer Roundtable. I think Letitia, unfortunately, is not going to be able to join us this afternoon. So Dr. Winder gets a little bit more responsibility during the discussion. And we're really looking at the panel's best thinking on what are the factors, big and small, that prevent us from seeing the outcomes we want to see in cancer screening and care. How do we accelerate around the adoption of proven cancer screening and care activities to reach our desired outcomes? And what are the innovations or opportunities necessitated by the pandemic that we could leverage to expand our capacity in cancer screening and care? So that's kind of how we're going to be structuring our discussion and a couple of different discussion areas throughout this next hour. The one thing that I do think is worth mentioning, and that we've really tried to focus our panelists, is to think about, we know what works. We have evidence-based interventions, health insurance coverage, patient navigations, things that we have seen over and over again work in institutions and facilities and community health centers that have increased screening rates or improved care or delivered more, strengthened access to those underrepresented, underserved populations. And we know there are a lot of national resources, and this is just a very small list of what some of those national resources are: the Community Guide, evidence-based cancer control programs from NCI, the National Comprehensive Cancer Control Program website and all their success stories that the CDC hosts, National Roundtable Resource Centers, the Comp Cancer National Partnership Resource Repository. There are many places that we can see best, offer steps and case studies for implementation. Today, we hope that conversation goes a little bit deeper and really looks at the factors that are preventing us from seeing the mass implementation, the mass adoption that we hope to see. Ryan, I'll pass it to you.
Yeah, absolutely. Thanks, Caleb. And I'm going to turn it to Rich in just a moment here. But the format that we have coming up, we're calling a fishbowl format. So everybody's used to panelists and somebody asking them questions. Rich is going to ask questions of our panelists, but our panelists will both answer Rich's questions and hopefully engage with each other as well. So the audience, we're hoping it creates the effect of you're listening into a good discussion across the table, not just a Q&A with Rich. While you're doing that, if you are in the Slido, and I'll remind you how to get in there in just a moment, you can feel free to put responses in the ideas section of Slido, so you can tell us what you agree with, what you see differently, and any additions. And we'll kick off each of these panel discussions with a poll in Slido. And then Rich will ask you to do a quick summary of what you heard the panelists say before we move to the next topic. And just a reminder, we have 3 topics today, which Caleb shared. Caleb, if you want, let's go ahead and launch that first poll. And remember, you can get into Slido by, Dion, I think, is going to put it back in the chat again. It'll take you directly there. You can go on your phone and put June Hub in, where it prompts you to enter a code. And go ahead, Caleb, let's pop over to Slido and get that up on screen, and we'll launch our first poll here. All right, and so our first poll, what are the 3 biggest factors? So you're going to pick 3, and Caleb, it just popped off screen there. What are the 3 biggest factors that prevent us from seeing the outcomes we want to see in cancer screening and care? So please select what for you are the top 3. Looks like we have people already voting. Excellent. We'll give it a minute. And Rich, I'm going to try to catch us up just a tiny bit as we move into this first discussion. So we'll tee up a 15-minute discussion here once our polling ends. Caleb, I think the screen went dark. So I don't know if anybody's seeing the polling.
I apologize. I'm having some trouble whenever I screen share. My computer starts to freeze up on me.
Okay. Let's see. Do we want to have?
I think I got enough of the sense of where things were going, Ryan, if you want me to comment on the.
Yeah, why don't you do that then, Rich? When do you see the poll and then open up our conversation?
Yeah, so this is like that aging test. You know, we're going to flash something in front of you and see how well you remember it. So a good challenge. Well, the one thing that did stand out for me was fragmentation was number 1 in people's responses. And, you know, I really, my first thought about that is, what do we really mean by fragmentation? I think it means a somewhat different thing to different folks. Here you go. That fragmentation is at the top of the list. I'll turn it around to say that there are clear opportunities for more coordinated action. That came out as something that struck me. I think these next 2, no surprise: access, financial barriers. I think that's going to be repeated time and time again. The one that surprised me a little bit, and of course I have a bias as being a primary care physician, is the lack of a robust system of primary care. If we rephrased it and said the lack of a robust system of primary care, to me it comes out a little bit differently, and it maybe relates to that fragmentation issue. Having a primary care clinician has been a trusted source of primary care is associated with dramatic improvements in outcome at more affordable costs, but access and fragmentation really emerged for me.
And Rich, why don't we have all of our panelists come on camera now, and feel free to engage them in some conversation.
Will do. All right, fantastic. There they are, Lisa, John, Keisha, Bob is there, and Tim. So we got the whole group. So it's great to see everybody, and thanks for being a part of this. Feel free, any of you, to pick up on any of the themes that the poll showed. But the focus of this first part of our fishbowl conversation is really on barriers. What are those factors, the big ones, the small ones? None of them are really small when they're multiplied by many people in many places, that are preventing us, standing in the way from seeing the kind of outcomes we want to achieve, both in cancer screening and the care that follows. So Bob, you want to start? Just take us off first response to those factors, big and small, that are serving as barriers?
Yeah, well, so in general, when we have aspirations and wishes for cancer screening, we always, at least in the US, acknowledge that we have an opportunistic system and that we could accomplish so much more if we had a system and systems to support cancer screening. And to your point, you know, if you had those systems supporting a stronger system of primary care, we would probably be achieving an awful lot more. But it's really quite sobering when we look at our colleagues, you know, in Europe who do have systems. And I think a very interesting statistic is now available to us. We've done this analysis ourselves. We, some 20 some odd years ago, you remember when Matt Ruffin published that article asking, so, okay, so if we all get cancer screening, how much of us are getting all the cancer screening that's recommended? And the number was startlingly low, and it still is. In the UK, 36% of women get breast, cervical, and bowel screening. And we'll all be surprised to hear in the US, we are only at 42%. So England's got a system, we don't, and we're pretty much neck and neck in how often we're getting regular cancer screening. So it reminds me that I think we're missing a lot of the important smaller opportunities and a real commitment to high rates of cancer screening across the board to achieve the rates we really want to see.
Yeah, thanks, Bob. So let me open it up to any of you. What are the barriers that big and small you think that are really playing the biggest role? Lisa, I kind of see you're ready to go there, so I'll put you on the spot.
Thanks, Rich. I'm just going to build on what Bob just said. One of the questions we're always asked at CDC is, when are you guys going to come up with a coordinated screening program? Stop the one-off of the cervical, the breast, the colorectal, just what Bob said. One of the biggest challenges we face at CDC and probably in other places is how things are paid for. So one test that we've done is with the National Association of Community Health Centers, where they're actually doing a module of combined screening and other well care to sort of not do the piecemeal body part thing, but to take a holistic approach to the patient. So I think that is a huge part. And I think health systems, until we get a national system, the health systems that deliver care really is where the action is. So that's all I have.
No, excellent. John?
Lisa, this is Tim. I just want to jump on that to say that, you know, I think that we do have an opportunity when we're educating our providers about combined screening to be able to help them understand that patients that come in for one, you know, there's significant differences in patients that are going to come in for lung screening versus those that may come in for mammography because they've heard about mammography all their life, but they've not heard about lung screening for the last few years. So this is a great opportunity for folks that are participating in mammography as a provider to be able to recommend to patients and to be able to follow up with, again, it's a system issue. How do we get that handoff into the primary care? How do we get that connection? But I also think it's an education on the patients to really understand the value of what screening is. Sometimes it's seen as something that I just have to do, but to really understand the survival benefit that patients have from getting screened. It's hard to translate that, but that's a dramatic win for us.
Tim, I love what you say, and also with what Lisa shares. And what's unique is that you're, I believe, a thoracic surgeon. Is that correct?
Yes, sir.
And I'm a breast cancer surgeon. And we all know our business, but even primary care has to learn so many different specialties in cancers for screening. And it's implementing that knowledge base and those guidelines to patients, which is incredibly difficult and hard to get, hard for them to find time. I guess what I'm going to allude back to Lisa and toss a question back to her from, is there a way from a policy perspective to some degree, rather than have piecemeal screening from different specialties, breast, lung, prostate, cervical, is there been a look or an opportunity that maybe in your way of thinking might be a great way to make screening one entity and how to do it? It's a payment model, yes, but have you ever, you alluded to it, do you have any aspirations how we could do that?
Well, we've definitely been thinking about it. I think, there are probably examples out there in private practice where they do this. But it really is about how do you bring in, and the big challenge here is that each screening test is so unique. The procedures you go through are so unique, some invasive, some not invasive. Some see the doctor, some go to get a radiology test, right? And so it's just really hard to come up with one size fits all. But we're working with the National Association of Chronic Disease Directors to do a cancer screening change package where we look at all of the screening tests that are recommended by the USPSTF as one group of instructions for providers. And so that should be, I hope, ready in the fall. If not, it'll be in the winter. But it's just one of those things where it's going to be a piece at a time, unless there's some radical change in how we do things in this country. So Keisha could probably speak more to the real policy, which is Congress.
Thank you, Dr. Richardson. Dr. Render, you had mentioned the barriers to making sure that patients have access to life-saving screenings. And from a public policy standpoint and more broadly, looking at the issue around coverage, of course, is something that is extremely important for us to think about. And we know that over 300 million Americans actually lost their insurance last summer in 2020 due to COVID-related job loss. The number of individuals who had insurance and lost their insurance and then lost their opportunity to be able to access life-saving screenings is extremely an important issue that we have to pay close attention to. And we know that cancer screening rates amongst the uninsured are typically 40 to 50% lower than in the insured population. So from a policy standpoint, one of the things that we have to keep top of mind is making sure people have access to affordable quality health insurance, that they can actually be able to then access their life-saving screenings, and making sure that that insurance is something that they can actually access. We saw during COVID just how important that access is. And something that we have to keep top of mind as we look at these issues.
We've had some recent success with Medicaid expansion, but it's from this point forward, it's going to be quite a slog, state by state. Any comments on both the value and what we're facing with Medicaid expansion?
Sure. We know that Medicaid is a safety net. It's a safety net program that should be a way for people who are low income or lose their job have access to insurance. We have 12 states that have not expanded their Medicaid programs across the country. That's something that ACS CAN has been involved in for many years, trying to work to make sure that all states look to expand their Medicaid populations to be able to make sure they have access to insurance. It's something that Congress is looking at this year as we're looking at the infrastructure package, and something that the Biden administration referenced in their budget that actually came out last Friday for FY 2022, looking at the ways that and policy changes that Congress and the administration can look at to make sure that people who are in those states who don't have access to expanded Medicaid program to have access to affordable quality coverage. So it's going to continue to be a conversation that we are going to see play out before us in the coming weeks and months.
Let me pick on another issue that came up in the poll that I'd love some comments on. And Tim, I've watched some of the work you've done around this, so maybe you could kick us off. And that's around what we call systemness, really functioning as a system. And it's true that there is fragmentation, but there are also steps towards systemness. And maybe I'm getting to solution rather than barrier, but maybe we could focus a little bit on the barriers to really functioning as a system.
I think that raises a great point, and I agree with you. You could think of it as a barrier, but I also think of it as an opportunity. When we have patients that are receiving care in a community, they may be able to receive access to certain services, but obviously we can't afford in a small rural community, for example, or even in certain urban areas, to be able to have full service access to those folks. So they have to connect to someplace else, so secondary, tertiary, quaternary care. And so how do we make sure that that connection is easy? Because it was hard enough to get them in the door to get screening. And now we've got to get them to not only go through a door, but get in a vehicle and travel and get to someplace else and introduce them to all those barriers over again. So I really think that what we need to be focusing on is a hybrid model of care, in a sense that we can facilitate inside or outside of a single healthcare system, a way to make those connections easier. And patients don't know how to make those transitions to go from one doctor to another. Those are doctor problems that we need to be able to solve and communicate amongst ourselves, so that when we have a patient that needs another level of care, we need to grease those skids for that patient so that they're going to go into that next system with as much information on hand as possible, and with as many questions already answered in terms of whether it's insurance or whether it's a lack of insurance, and what's necessary to be able to help them make sure that they're going to get to that level of care. Because now you've got a patient who has a heightened sense of concern, something's been found, and now we have to get them into a system in a timely manner. Otherwise, they feel like they are left out. They feel like they are being ignored. They feel like that nobody's responding with that sense of urgency. So I think finding a way to really simplify that hybrid level of care and the transitions of care between different institutions is going to be critical.
So I'll follow on that if you don't mind, Rich. So one of the things that everybody on the panel here has probably heard of or talked about or worked with are community health workers and patient navigators. So in our screening program at CDC, we allow their funding to go towards patient navigation to do exactly what you said, Dr. Miller, to sort of work the system and help them figure out how to get from one point to the next point, because it is very complicated. I can barely do it myself sometimes. So, but yeah, that is actually, and that's a way to do it in the community as well, community-based community health workers and navigators. And that's something that CDC is funding, a huge project coming up here fairly soon that just closed, to look at how community health workers can facilitate vaccination for COVID, but that same person could do all the rest of the things as well.
Lisa, that's right. And we need to find a way to make sure that that's going to be a preordained connection. That's not
right.
Now I have to create this when I have a patient in front of me who needs something.
Right. And the other thing has been making the business case to health systems that this is something that will eventually help the bottom line. People showing up for their appointments, understand what they're supposed to do, prepped for their colonoscopy, whatever the thing is that you're trying to do. So I think there is a business case to be made to
Rich,
administrators.
we have about 1 minute before we turn to your summary.
That sounds good. John, you just spent a year in the President's Cancer Panel, and so many of these barriers came up. Could you just comment a little bit on, particularly if there's some barriers that we haven't touched upon that you learned about through all the research you've been doing?
So our panel's been working since March of last year, really on this topic, and we've had the privilege of having many public meetings, experts, and just a couple of the lists we're running short on time. Community health workers and a workforce. We need a workforce to facilitate cancer screening, but of course, many other things. It is also a key component to touching those that we leave behind, disparate groups, disparate economic, race, urban, rural, all of those. The workforce, but the mechanism for creating that and enhancing that is an incredible opportunity. Another couple of things that come across my mind is that messaging is very difficult. We all know how important it is, but getting that message out, not only to providers, but to the public, even more importantly. And again, very diverse groups, the groups that we leave behind is a key opportunity. Telehealth is an opportunity that now we can accelerate. Next topic, but I think those are some of the thoughts that we've touched on, and how can we also fund some of these things, not the bigger policy, but some of the actionable items. So hopefully that's helpful, Rich.
Yeah, that's terrific. So thank you so much for this first fishbowl discussion. It's terrific, and we'll get to build on it in the next two, which I'm looking forward to. But I have the opportunity to do a little bit of summary, which I appreciate. So first and foremost, and this will not shock anybody, when you talk about how we're going to get care and screening done in the United States, access is going to emerge at the top. That's going to demand both small, but particularly large policy as well. We just have to be relentless. We have to keep solving this issue of how we help people get access to a trusted source of primary care and then all the downstream care that they require if they have a diagnosis of cancer. The second thing that emerged for me was messaging. And it was mentioned more than once that we all take for granted the value of preventive care, but it's a low priority for most people. In our community health needs assessment here at Penn, cancer doesn't even emerge on the list when you ask the community. There's lots of daily issues that are much higher on their list of priorities. So effective messaging is key. 3 is systems. And Tim, I loved what you said, that who's responsible for providing the system? Sure, if you have a very highly literate, well-educated person with high health literacy, with a strong social support network, they'll navigate their way through. But how many people can really effectively do that? Lisa's comment says, "I'm not sure I can do it," was really right on point. So that's our responsibility to create that kind of connection and systemness, and we're going to explore models for that. And then finally is this issue of experimentation, pushing the limits of a new healthcare workforce. That was a strong theme. And again, if you make it into a barrier, then it's the lack of an innovative workforce that can reach people where they are that's playing a role. So I think we did a good job on barriers. We'll look forward to moving on to some solutions.
Excellent. Great summary, Rich. We'll keep you on deck here for just a moment. We're going to our second issue, which is accelerating the adoption of proven interventions and how we might do that. Before we dive in, we're going to do another poll. So Caleb, if we can pop that poll up on screen. And this one, please review the same list of barriers below. It's the same list you responded to last time. Now, considering impact and feasibility, so considering both those factors, where should the cancer control community focus our attack to better achieve desired outcomes? I think, Caleb, we have up to 2 options on this one, correct?
This one's just one.
Just one option. Okay, got to pick your top one. And as people are voting, I'll just remind everyone, we have a robust conversation going on in Slido on the Ideas tab. So check that out once the poll is done. We'll just give it another moment here on the poll.
And Ryan, I'll also mention that in the Slido, whenever you're putting a comment, if you like a comment, you can upvote that comment in Slido, but you can also reply. So if there is a conversation, if you like what a colleague has put, you have a response to it, you can do that through the Slido platform and we'll capture those conversations.
And if you're saying, what is Slido? You may have joined us late, as I know some people did. Welcome, welcome, welcome. If you look in the chat box to the Zoom, Dion will put the link to Slido in, or you probably see the QR code right on your screen. So you can just take a picture of that and instantly get the Slido on your phone. Rich, we'll just give it one more moment here, and then maybe you could comment on what you see on the poll, and then we'll just do another 15 minutes of dialogue. So it actually looks like maybe we're maxing out on responses. So Rich?
Yeah. Listen, I'm not surprised that people would focus on access. What was kind of interesting, the big shift that we saw here as to where we should focus is that focusing on fragmentation moved down. I think you could debate that. Maybe we will debate that. I think there may be some opportunities in tackling fragmentation that the cancer community could really address. And the challenge, I think, if we put access to health insurance and other financial barriers at the top, no argument, critical issue. But I think figuring out, as we're about to discuss, what can we actually do as a cancer control community that will improve health insurance and overcome financial barriers is going to be really critical. And the only other one I'll quickly mention is this one that came out third. national, local commitment, that's a place where I suspect the cancer control community could really resonate and try to leverage and create the energy to produce that sense of commitment at both local and national levels.
Rich,
All
if
right,
you
gang.
engage our panel, we'll get the panelists back on video.
There they are. They're ready to go. They're chopping at the bit. So you get a chance, and I knew that we were spilling over into getting some of the solutions because it's a solution-oriented group in our first section. But that's what we're going to focus on in the second part of the discussion: is how do we accelerate adoption of proven cancer screening and care activities to achieve the outcomes that we all want to achieve. So, what are some of the things that yes, are proven, but you think maybe also are aspirational, really pushing the envelope of what we need to do as a nation to see better cancer outcomes?
Oh, Rich, one of the things that I'm reminded of is that during our 80 by 2018 campaign, we had a number of institutions and other health systems that roared up from very small numbers of colorectal cancer screening to quite high numbers of colorectal cancer screening. What we commonly see is that in terms of an encounter-based model of healthcare, probably everybody thinks they're doing as much as they possibly can, but they're unaware of their numbers. And when a health system became aware of their numbers and set a system-wide goal to achieve high numbers, many of them did. I mean, I look at our breast cancer screening rates, they've not moved in the last 10 years. And actually longer, last 15 years. And it seems to me that most of us are probably not even aware that they haven't moved, but we aren't seeing a sense of urgency to actually make sure that these numbers are as high as realistically possible, and high, not only high, but high rates of regular screening. So it does seem to me that if this were a national movement to have every system know the numbers of and the rates within the patients that they're taking care of, there would be a greater desire to use the proven tools that are in place to get those rates higher.
And I would just add that looking at this important issue too, with the health equity lens and health disparities lens is even more important as well. And trying to figure out how do we look at Black and Brown communities that we know oftentimes do not have access to the life-saving screenings. And because they don't have coverage, they don't have ability to actually get these important screenings, and being able to invest in some tried and true programs that have successful outcomes. And Dr. Richardson and her colleagues work on a number of those programs at the Centers for Disease Control, our National Breast and Cervical Cancer Early Detection Program, the Colorectal Cancer Screening Program that provide grant fundings to states across the country. The National Breast and Cervical Cancer Early Detection Program is actually having its 30th anniversary this year, and we know that that program's successful, but we know that it's underfunded. And there are people who are not receiving those life-saving screenings because there's just not enough funding to provide to states across the country to touch the people that need access to those screenings. And from an advocacy perspective, it's something that ACS CAN is engaged in during the fiscal year 2022 appropriations process. We are having that conversation with members of Congress and with the administration, saying that this is something that we know is a tried and true program. It's a way to address screening and a way to touch low-income communities as well as minority communities from that health equity, health disparities lens that we know that we can be successful.
Oh, terrific. So, John, I see you. Go ahead. I sense you're ready.
You're really, Keisha, thank you for sharing all of that. And you really outlined so much of the silos that we all work in for the same purpose, to help others and improve cancer screening and ultimately cancer outcomes. And Bob mentioned at the very beginning that the colon cancer 80% goal was created by the colorectal roundtable. Is that correct?
That's
Rich.
correct.
And so what's fascinating to me, in some ways, being an outsider looking in at this system that we all try to do with cancer care, is that messaging is lost, messaging of guidelines, getting to patients, getting to the public in formats that they need. That is done well at roundtables because a roundtable, for those who are not aware, there are about 4 of them. Colon cancer, there's a HPV vaccination roundtable, there's a lung cancer roundtable. So you kind of have the major stakeholders there, but advocacy and representatives from different groups at the table, and they work together for the same cause. And it's just like us getting together. We are all working together on this panel and everyone on this call for the same cause. So with that said, roundtable addresses messaging because it creates sophisticated digital messaging that then you can translate to those that are left behind in a community or in a language or in a different area. We can also then allow guideline makers, American Cancer Society, United States Preventive Task Force, to get together at the table and identify what their common goal in their disparate languages and work together and share that. How do we get that out? I think that there's an incredible opportunity for amplifying roundtables, especially for other cancers we haven't covered beyond colorectal and lung screening cancer. Breast cancer. I mean, Bob just mentioned we haven't raised the table and there's a lot of controversy, but even when you have people that are conflicted, you get them to get at the same table. We're all doing the same thing. They work together. So that would be my take. I think that we really need an expansion. Funding it is the question. And there's some creative ways to possibly do that for other tumor types.
That's great, John. I'm going to switch the focus just a little bit. I'm capturing all these points, and I'll try to summarize them. But Tim, you're again, you guys have done some pretty amazing stuff in Kentucky. And when people say, what state in the country is going to knock it out of the park with cancer care? Kentucky is not the first one they think of, but you've done it. Leadership in lung cancer, tremendous in colorectal cancer. Comment a little bit on some of the lessons learned that you think can be translated, things you're still working on, but things that the cancer control community needs to be really taken forward.
Well, thanks for that. I appreciate your comments, and I think it all comes down to feedback. When we've looked at what we've done in lung cancer screening, part of what we've done is through our Kentucky Leads Collaborative statewide study of implementation of lung cancer screening, and we've provided reports back to these programs that to kind of take the blinders off. Everybody thinks they're doing a great job, but it actually shows that there are areas that you need to improve. And your tobacco treatment and your lung cancer screening program is not really where you want it to be. Your eligibility criteria is slipping a little bit over the last 6 months. Other elements that we can provide. And I think the same is true in our colorectal screening program that was studied by Tom Tucker and others that have been able to look at this, but they've provided reports back to facilities and back to regions. I think that we could do an even better job if we were to provide those reports based on other demographic factors to be able to help us identify where we're leaving people behind. Because if we look at an aggregate of a facility and we say we're doing a great job, that's fine. But when we really look at the breakdown of those patients, they may not all be receiving the same thing. So I think we could, and maybe it's by geography, distance from the facility, maybe it's by socioeconomic factors, racial factors, other elements that are present that are standing in the way. But I think that a lot of it comes down to feedback. And we've seen this change, even in our COC standards, when we have had states like Pennsylvania that have participated in patient public reported outcomes. And we see those outcomes reported by facility on standards and their compliance with these various quality measures. And we see improvement in those quality measures. We're all a competitive bunch. And so I think that the more we see each other and where we stand compared to others, the more we want to make that better, especially if we see folks at risk.
These are wonderful points. Lisa, I've had this discussion right here since I've been to Penn. How do we measure disparities? Do we measure disparities at the level of those people receiving their care at Penn? Or do we measure disparities at the level of the people living here around Penn, whether or not they get their care from our facility? And I think shifting, I'm editorializing,
right.
but shifting to a report card that is not just at the level of patients, but it's at the
Right.
level of people living. And the CDC has always done that, right? I mean, those are the data
Mhm.
that the CDC is looking at.
So I think so. Well, there are several answers, Rich, but let me see if I can figure one out here. But
Pick any you wish.
I think it would be, what you're saying is true. The community is really the place, but what is the community? Is it your geography? Is it your facility? Is it the providers there and the people they serve? I think whatever you choose as that community, you have to focus and make sure you're concentrating on doing things better in that community or finding those people. And like in Philly, I'm sure there's plenty of people there that, could benefit from the services of where you work. To add on to what was said previously, also though, it's sort of the translation and dissemination is a bear, right? So we all know what to do. Health facilities know what to do or what they want to do or what they should do. But what we've done in the programs we run is really go into the clinics and show them how to do it. And there's a lot of the we don't know what to do out there, regardless of what health system that you're in. So how do you, and that gets to your point of the community. What part of the community do you reach out to, Rich? How do you find those people that haven't been screened? Then how do you set your system up to do that? And what we use currently in our programs are the community guide recommendations, which really are, been proven to increase screening in clinics and also work with the health systems those clinics are in. So it all depends on what your community is, but sure, I'll go for the geography that you're living in. And can you all work together as facilities and doctors and other healthcare providers to make it happen in Philadelphia? So.
Have any of you seen some particular examples of mobilizing a workforce? We mentioned that under barriers, this opportunity to create a new workforce. Are there some examples where you've seen that really work and where the cancer control community has helped that happen?
No, where we've seen it work in Kentucky has been with a group called Kentucky Home Place. These are lay navigators that live in Eastern Kentucky and Appalachia, and they are directly connected to population health scientists, and so they have evidence-based information that they're able to go out through faith-based communities or throughout communities that are disenfranchised for a number of reasons, and they're able to translate this message. And when they go out with a specific purpose, they are able to demonstrate a specific result. And so I think it's been really impactful. I think Alabama has seen the same thing in the work that they've done, and Dr. Partridge's work and some others. And so, I think it's definitely an opportunity. If we have a very specific message, then lay navigators can carry that message forward. But I think where we can succeed even more is that if we have a direct connection between those lay navigators and providers of expertise to be able to, because they're going to uncover things and they need to have a backup. Right. They need to have an answer that brings them in. So I think that's where our network system and other areas can come together. But I also think that's where facilities like COC accredited facilities can all work together to be a de facto network so that they are a resource in the community. So we're anxious to see more rural programs participate for that reason.
So I'll just add to what Tim was saying, because I think he's really on target here. The Metropolitan Chicago Breast Cancer Task Force has demonstrated a remarkable influence on reducing the disparity in Black and white women's breast cancer deaths through a coordinated attempt to understand every aspect of the barriers and the problems that combine together to contribute to that disparity. Chicago's the one city out of 50 that actually has shown a drop in that rate of disparity. And it really speaks volumes to what can be accomplished if there is a announced and visible mission-oriented approach. And I think the more you have the institutions engaged collectively into something that everybody agrees is important in a population, then the greater the progress you're going to make.
A number of you, this has been a loud theme of this discussion of goal setting, data, actionable data that's local. It's really been a very powerful theme of this discussion. And I'm trying to build a bridge in my mind between the national roundtable efforts, which can give the tools and set a big goal, how does that bridge locally? Is that, do we need more local versions of this? And I'm not advocating, I know there's been debates, is that a cost-effective model to bring together kind of more local consortia of organizations? But I'm curious, how we make this as local as it needs to be.
Well, I think the consortium, the state-based consortium, are the system that CDC provides funding for, and others.
Yeah.
Those are very broad consortia. But what we've seen in Kentucky and others is that if you develop a focused area on lung cancer, focused area on colorectal cancer, then that can become a nidus for change in your state at the state level, speaking the barriers that are present in your own community.
And Bob, quick final word, and then I'll wrap it up.
Yeah, no, I think there's no substitute for this. And actually, there's enormous enthusiasm for this at the local level. What we did in Georgia was we tied our state level roundtables, colorectal and lung, to the comp cancer program, so that you do have that kind of coordination and you don't have yet another group that even engenders concerns of sort of competition or who's in charge. I mean, ideally, you want to build greater and greater engagement and coordination, but ultimately that's a perfect partnership between the national and the local level, and especially providing guidance as to the best way to do that and to communicate best practices that other states have had success with.
Yeah, so, and I'm sorry to interrupt the conversation. We'll get one more shot at it, but I want to keep us on time, and I'm going to do a quick summary because I touched on a few of them. But boy, in that short conversation, we just hammered home a few points. One is the power of bringing organizations together. We talked about that nationally. We talked about that state, and just to pick on Bob's final point here, if you have this broad cancer consortium at the state level, when you can then spin off from that a more focused endeavor with a focused goal, you will bring in additional organizations because that's their issue. They may not have been a part of the whole statewide thing, but they'll come in on that issue. So it's a chance to bring in more. Two is funding. You need funding for this work, and figuring out how to fund it, it remains a goal. I'm not sure we totally answered it. Advocacy is part of it, but we need some funding solutions, both nationally and locally. Third, and perhaps the most powerful message of all here, was data. And I thought you guys did just a beautiful job at saying, we're not just talking about high level, don't just show us a high level number. We're talking about actionable data down to the level of neighborhoods that doesn't just say what the cancer rate is, but also what screening rates are, what the barriers are, what insurance rates are. So you really have something actionable. And if I may kind of pull from Tim's comment, some public sharing as well, because people do feel this sense of competition. They do. I remember when we went out with colorectal cancer screening rates, the states that were number 50 or 49 on the list were not happy to be 50 or 49 on the list. That definitely was a motivator. Specific measures that are actionable, that bring together organizations motivated by and driven by the cancer control community that's very passionate about these issues. So there you go. We have a pretty impressive roadmap.
Excellent. Thank you, Rich. Thank you, panelists. We're going to turn to our third topic today, which is about what innovations and opportunities that came out of the pandemic response that we can tap into, that we can leverage. And so, Caleb, if we can pop open the third and final poll, and hopefully you see it on screen. The question is, what are the innovations or opportunities necessitated by the pandemic that we could leverage to expand our capacity in cancer screening and care? And you get to pick up to two answers. And Rich, we'll just give that a minute as usual. And then everybody's got the pattern now. We'll turn it to you to respond to what you see in the poll. We'll ask some questions, you'll summarize, and then we'll close with hearing a bit from Caleb. Just the last couple minutes, we'll close with next steps with Caleb.
Yeah, and Ryan, if I can just add here, we have some ideas down for this particular poll question, but we will have, and I'll be launching kind of our ideas discussion panel in Slido here shortly after this poll closes, after Dr. Winder responds to it. If you have other ideas, put those in there. Let's keep that conversation going. It's been really, really robust, and I'm sure our panel is going to look forward to reviewing some of these comments that we're receiving in the Slido as you all are talking as well.
Rich, I think we have a pretty good sampling.
Okay.
All responses.
Yeah. Listen, nobody, we'd be quite shocked if telemedicine, telehealth weren't at the top of the list. Although as we get into this discussion, I'm going to push the panelists, so get ready to say, how do we do that? I mean, how does telehealth really accelerate this particular set of goals? Because for those of us who've worked with it, there's some barrier elements to doing things through telehealth too. So I'm going to push you on that. But the second thing that didn't quite come out in the poll, unless you kind of piece together a few of the answers, is that particularly through vaccination, we went very, as it's gotten, the first wave of people who were chomping at the bit, to get vaccinated, they were desperately seeking a place to find a dose. And now we're at what all of us in public health are pretty used to, which is now it's getting tough, right? You have to go to where the person is. You have to make it easy. You have to address their concerns, public education. And you may have to reach them in innovative ways that you never did before. Vaccination on vans, vaccination in homes, and these kind of under this broad rubric of community navigation programs. When we wanted to suppress an outbreak in a nursing home, we had to really figure out what was going on in this nursing home. I think that the pandemic gave a face to why disparities occur, and it gave a roadmap of just how tough it can be to really take your healthcare deliveries local and powerful enough. Let me not skip by the item that came back second, which was more innovative ways, as we talked about earlier, to coordinate based on risk. Very powerful lessons, and a chance for us to really think how we do this in the cancer space. All right, everybody, you've heard the questions. What are those innovations or opportunities that were necessitated by COVID, but that we could now shift and leverage and learn from? And I'm going to push you as hard as you're willing to be pushed to say, how is that really going to happen? How does telehealth really help us? What are the opportunities there? John, I'll put you on the spot first, because I just know how many times during our year together these issues came up. I mean, this was a big focus of the work. So why don't you kick us off?
I think telehealth has played a role, and it's an incredible opportunity. And the payment model, which was sort of brought from paying $10 for a visit to, let's say, $70, so it compensates you reasonably well as a provider. But it's a temporary elevation, but it's probably going to be here for some time. With that said, it allows us, number one, to navigate, to offer testing to those that do not want to come in to see us, although there's still going to be some people long-term that are not going to want to come in to see us. It also, almost more importantly, helps us navigate people through abnormalities, an abnormal mammogram, an abnormal colonoscopy, an abnormal lung cancer, low-dose CT, and just gathering the patients to order it. I would tell you, on an innovative perspective, Rich, I think that there's an opportunity to allow for Medicare to pay once every 3 years a telemedicine cancer screening office visit with that CPT code, to allow it to be at least pay for that engagement and that expertise, and allow doctors and physicians and providers to offer that. And I think you could bring people in to our screening system that otherwise may not even ever want to come to our system through the front doors of a hospital or clinic.
John, I think that's really important. I think there's some real, and it's been interesting to watch the parallel between what's happened in the pandemic and with vaccination, with what's been going on over a short period of time, with what's happened with our experience in cancer screening over a long period of time. And so I think the issues that it has raised have been very important. And I think one of the primary ones is trust. And I think that if we can get people to trust the role of cancer screening, then we can break down many of those barriers. And so I think making sure that we're sending a message that is speaking in a language that they are interested in and that they trust, whether it's their faith-based community or whether it's others that they respect, to be able to see a message that is saying that this is important, then I think that's hopefully going to make a difference. But I fully support your position. I appreciate what you're saying.
So
Go ahead.
I'll follow on that really quickly. So to Tim's point and to John's point, what you mentioned might be one of those ways we could get like the one system thing together for the screening, John, like bringing people in for one visit for those types of things. So I like that idea a lot. So I picked one of the choices. I can't remember exactly what it was, but at the end of it was health and wellness. So I think if you're going to talk about changing a message, what we're trying to do and what I would like to do as director at CDC is talk about cancer screening as a wellness test, not as a disease finding test. Nobody wants to find cancer, but guess what? Cervical cancer and colorectal cancer, you prevent cancer if you find a lesion, right? The other ones, people live longer if you find the cancer when it's smaller. So it's one of those things about changing how we talk about the work that we do as well. And I think that would resonate with people because everybody wants to stay well and nobody wants to find cancer, right? And so it's just sort of trying to think logically about how I like to be spoken to by my position or whoever. Keisha?
No, thanks, Lisa. I was just going to add on the telemedicine side too, that it's an opportunity to reach some patient populations that had a harder time getting to an office, being able to use a smartphone and being able to have an opportunity to have an interaction with a primary care doctor for their child or for other issues. And it's one of those silver linings in COVID, as we like to say, over the past year. And it was an opportunity to have a live demonstration project. I think all of us on this call know that there were a lot of concerns about telemedicine and expanding telemedicine, and do we want to actually pay doctors more to not have to have a face-to-face interaction? And we were able to see it all transpire in a live demonstration project, and it has a lot of bipartisan support. And conversations that we're having on Capitol Hill, there are a lot of members who want to make sure that the policy changes that are set to sunset don't sunset. It's not a done deal, but it's something that I know with ACS CAN that we're continuing to have conversations about, because it's another lever to pull when we look at making sure patients have access to their healthcare system in a way that may be a little different than we used to think about it pre-COVID.
You know, I'm going to follow up on what Tim was saying about education. We're all, I think, still impressed when we see the proportion of the public that responds that they think mammography prevents breast cancer. We have not properly communicated the importance of these preventive health measures. And I think, frankly, if all of our organizations, I mean, public health really took it on the chin during this pandemic. I mean, we really had some wins, but we also, got some black eyes over, disparate information and disagreement and things like that. But if we could come together and support the most trusted voice in communicating this information, which is a healthcare professional, then we would probably make a lot more progress on making the case, helping them to make the case that, you just have to do this. You just have to have regular cancer screening. And to Lisa's point, you're going to have the reassurance that you're healthy, that you've had a normal test. And if not, you'll have had the advantage of why we recommend cancer screening, which is to prevent cancer or find it early. And it really does need to matter whether you have had these tests. So we're going to be keeping track And this may be where telemedicine can also have an advantage to just, do a reach out that says, okay, you're due for these things. It's important to us and you that you get them.
Bob, I think ACS did a great job of developing a message of return to screening in your materials that you put together. And the Commission on Cancer adopted those and put it out as a PDSA to 1,500 programs, and it's had wide success with adoption for being able to get more patients back into screening. So I think working together with a consistent education message would be wonderful. John, to your point about telehealth, and boy, I hope we can see persistence, and we'll lean on Keisha to help this happen, to see persistence of these policies, because I think it's not just screening, but look at clinical trial accrual and the fact that we changed the rules regarding remote consenting or getting patients into clinical trials. And I think that may be a lever that we can push to be able to get more diversity in our clinical trial participation as well.
Tim, it's interesting as you start thinking through things, you realize how they work. Sometimes they're a big swath movement. Other times they start small. But as Lisa put together, I thought brilliantly, bundling of different cancer types for Tim, my patient on video. That's not going to include breast, but it's going to include lung, it's going to include colon cancer and prostate cancer. But if you create or influence or guide our system to create a payable model for screening, telemedicine, but it requires bundling the appropriate cancers, you then start a process that then everyone, our workforce, including myself as a physician and nurses, start to learn and do and slowly implement. So cheers to Lisa on that. And I think there's some neat opportunities.
Yeah, one of the things that happened here at Penn, we have an enterprise-wide goal around colorectal cancer screening. And what a lot of people, until you kind of are measuring it, you don't quite realize until you're hit over the head with the reality. When you miss all those colonoscopies and then you're measuring your outcomes, say, well, we got the colonoscopy rate back up very quickly. 3 months, we got the colonoscopy rate back up. Guess what? That's not enough to overcome the number you missed. That's just keeping up with the number of people you needed to hit. So as a system, we've switched to a much more stool-based, population-based approach with sending out fit kits and taking a deeper population dive. And I think that's been eye-opening because we've recognized, one, that we should have been doing that all along. We'll reach more people. Two, that we can take that population management approach that came out of the necessity of COVID, but it could be applied actually to other issues, which I thought was very important. We've talked a lot about screening, but I just comment a little bit. A number of you touched upon what could be done for patients with cancer or through going through a diagnostic workup. Could you comment a little bit more on some of the innovations that we've learned there? Maybe Tim, again, you could kick us off since you and John are in the cancer treatment space.
Well, I will. Thank you. I will say that there's a lot to do for cancer patients that doesn't have to do with giving them chemotherapy or scheduling them for an operation or pushing a button for radiation therapy. These patients need to be surrounded with tools that can help them with nutrition, help them with their caregivers to be connected, can help them with other aspects of distress management and social work. And I think that, when we think of nutrition, for example, it's not just a matter of you need to eat more, you need to eat less, but it's do you have access to your food for you and your family, and do you have other systems that are present? And Lisa, I appreciate your measure of patient well-being, and we actually participated in a study through the Launch Collaborative that twisted the idea of distress monitoring around to a measure of well-being, and to say, okay, where's the positive? Your score is 10. That's at a high level of distress. But what if we twisted that to say your score is 10 because you're doing great? Your score is a 2 because you You've got all these things that are piling up on you, and we need to really look at how we can help you with those things. I think telemedicine has a great opportunity to be able to connect other providers that aren't typically, they come in to see me and schedule an operation, and I'm talking to them about what their surgery and the risks and the benefits and the timing and where they go to get their COVID test or whatever is necessary. I may not be talking to them about nutrition or survivorship or other aspects of their socioeconomic factors that are influencing their decisions or their ability to complete their therapy. So I need somebody else to do that. And I need that. I think it's going to be best done by telemedicine.
Yeah, to speak to those issues. So one of
Yeah,
the places that
go
I've
for it.
noticed reading everything, trying to figure out what's going on has been mental health care. Those people who are able to take advantage of it, 70-80% of those visits now are online and people are benefiting from it. So I think you're absolutely right, Tim. There's a whole lot more we could do. We just have to figure out how to do it and get the system to cooperate. How's that?
And we need the great access to mental health care, but with less threats to our mental health. That combination will be perfect. John.
Just one last thought, and I think it covers so much of this aspect, is that we know what works. We try to make it and package it in a way that works even better for more and more people. We're not perfect in the larger cancer realm, medical realm, community realm. But what we do not do well is, and here's a great example. Tim said we've got a new initiative. We then spread it out from the ACS about cancer screening to our 1,500 different members. It doesn't go much further than there. It doesn't get out to the public. It doesn't get out to the doctors in the community. We have to find a better way of communicating to the public about what we feel that works and helps people, but also more importantly, and I hate to say this, but I believe it's true as a messaging person, we have to communicate with physicians and providers in the same language that we communicate with the public. It's more effective, and we also have to make points very quickly, and we have to do it in a digital space that's engaging. And I think we'll be more effective if we all stand up, learn those mechanisms of communication, and do more of it. So I task also the organizations also here to do so.
Yeah, what a great role for cancer organizations. So Ryan, I don't know what it is. Your face pops up and immediately I just want to summarize things. It's incredible. So
Your reaction. Go ahead.
Yes. Listen, there was so much in there that was really powerful. I was trying to capture my notes here. So these aren't necessarily in order, but every one of them is a powerful idea, and in part came out of COVID. And the one I put first was, who is giving you the message? And is that message a trusted source? And is it the right language? And is it culturally sensitive and appropriate? So this leveraging the sources of messaging, I think we've certainly done some of this. I'm not suggesting that we've not, barbershops, faith-based, but we got to keep learning about how do we create trusted messaging in the right language for all audiences, and then leverage the partnerships to help deliver the message. That was really powerful. Number two, health and wellness. That was a real theme of this discussion. This is about being well. It's about being healthy. How do we leverage that in the discussion? Number three, bundling of services. We're going to have to dig in a lot to that, because Medicare will say, well, we do have the annual wellness visit that we pay for. But I think we were talking about something beyond an annual wellness visit. And number four, we were saying greater flexibility with that visit, that there may be a chance to bundle some services and deliver them remotely, which would not meet, through telehealth options, which would not meet the criteria for an annual wellness visit. So we need to work on that. And then when we come to cancer care, I thought this was really crucial. Really being smart about where we leverage the telehealth. And this, we've seen it, I think no argument, we've seen this most effectively in the mental health space during COVID. But this opportunity to leverage services through telehealth and make sure that whatever model of payment we come up with, which I suspect is not going to be just sequential fee for service, but a new form of payment model that bundles payment, includes these services which make such a difference for patients. And then the one that we didn't quite mention, but I'm going to throw out there, actually two. One is, shift to a population health focus from a system standpoint. But the other one I would just want to bring back in is this chance to really think about the workforce that we brought in to help with vaccination and make sure that we're taking this new workforce and think about how they can help with other these wellness services. But tremendous number of ideas in a very short time. So thank you for that tremendous discussion.
Rich, thank you. And I